All right, we're live.
Okay, we're back. This is Senate Health and Welfare, April 22nd. We've had a little break and now we are meeting with our Ledge Council to go through at H210 and H46 for H210. I think based on the testimony that we've heard, we may have some further suggestions, but we're going to try to wrap our work up on this bill so that we can vote tomorrow morning. That's where we are. Katie, thanks for being here.
Good morning, Katie Micklin, Office of Legislative Counsel. I'm going to pull up the document. Okay, are you seeing draft 2.1 at the top of your page?
Yes, we are.
Okay, perfect. There have been amendments requested. This is a strike all amendment and the changes have been highlighted. So I'll walk you through those changes. If you remember, the first section is the findings section. There were no changes to that section. So that's why I'm starting at section 2, which is our legislative intent and purpose section.
So we heard testimony this morning that perhaps there should be some data included in the findings section related to our Abenaki or our Native American population. Whether the Department of Health has that, if the Department of Health has that, it would be helpful, I think, to put something in the findings on that. And I don't know if I can't see anyone in the committee that is disagreeing with that comment.
Okay.
And Katie, I'm happy to try to dig up that data or language to include it before we meet tomorrow.
Perfect. Thank you. So in section 2, we have lead-in language that says, to this end, the General Assembly believes. And there is a new subdivision here. I believe it's 7. Yes. 7. And this just recognizes the challenge of terminology and definitions. So this language reads that definitions of racial categories and identities can be difficult to agree upon, as they often create hierarchies and comparisons that center whiteness, prioritize one group or identity over another, or fail to recognize historical inequities and oppression. Definitions also shift over time as broader cultural norms change. While potentially problematic, in order to align with the data collection standards and create consistency, this bill does use the term non-white as defined later in the bill, and also seeks to create new definitions that better reflect racial and ethnic identities and categories. And this last phrase kind of alludes to new language that we'll see as we continue to move through this draft that looks to get more clarity as to what definitions we should be using throughout.
Katie?
Yeah. So this.
Oh, sorry, Ginny, go ahead.
Yeah, no, just really quickly. I think this relates very much to testimony from Clarissa Coleman and then the concern that I expressed about moving forward on the definition. So go ahead, Ruth, go ahead.
Thank you. I was just going to say, could we use a citation there in that last sentence and also seeks to create new definitions and cite where we seek to do that?
Yeah,
so
we could say pursuant to, yep.
Yeah, that would be great. Thanks.
Section 2:7. Okay. Making notes for myself so I can go back later. Okay.
Did I not say Marissa Coleman? Did I say it right? Didn't say it. Okay, go ahead.
Okay. So now we get into section 3, and this is where the new chapter is being created on health equity. It creates the advisory commission. But the first section is definitions, and the committee received testimony about recognizing cultural humility. So that concept has been woven throughout whenever we are referencing competency to also include in that conversation humility. So the way we have added that in is right into the definition. Cultural competency means acquiring both humility and a set of integrated attitudes, knowledge, and skills, etc. And you'll see this change at least one more time, maybe twice, as we move through the bill. So we're still in the definition of cultural competency. And there's been a new subdivision that's been added in terms of what we mean when we say cultural competency. And so again, this is kind of bringing that idea of humility in, saying that this includes the ability to recognize the importance of communication, language fluency, and interpretation in the provision of healthcare services, and assist with access to interpretation and appropriate communication services.
I just, Katie, thank you. I just want to add this, not only did a couple of our witnesses, Max Barrows and Kaya Morris, mention communication as an important addition, but also I spoke with a linguist who does work in this area, and she suggested adding language that was really specific to communication and as part of cultural competency. So that's where this came from.
Okay. So I've moved out of the definition section and now I'm in the advisory commission language. And there has been an update with regard to the membership. You'll see in this on line 7, this subsection J, the addition of the chief prevention officer. This is a position that I want to say was created within the past 3 years. And this person is located within the secretary's office in the agency of administration.
Yeah, don't leave the membership yet, because we might have another suggestion. We need to talk about something. But I can't remember whether maybe 3 or 4 years ago, but the issue was raised about having the executive director of the Vermont Developmental Disabilities Council be added in as a member. And we heard some fairly compelling testimony on that. So committee, is there any reason why we would not include that? Does everybody agree with that? Just say yes.
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 Does
Yes.
anybody not agree with that? Okay, good, because I can't see you all. That's great.
Okay, I will reflect that change in the next draft. Let's see. So I'm scrolling past the membership. And then in subsection C, this is the powers and duties of the advisory commission. And in this subdivision 1, in the version that came over from the House, well, it said that the commission is to provide guidance on the development of this office that's going to be created, which shall be established based on the commission's recommendations. And the language said, I think, to as soon as fiscally possible to do so. And so the proposal here is to put a date certain in, that the office will be established not later than January 1, 2023.
So the question is, if the bill goes into effect in July 2021, and this group gets organized, is there a date for the first meeting of the group? Do we have that in place?
I'm scrolling down to take a look.
I was thinking one leads to the other. So if there's a September.
September
if-
1.
Yeah, so if they're meeting by September 1, 2021, then it's January 23 seems an awful long distance away. So I'm
So
wondering
one,
if we give them a year to do this, would that be sufficient? So go ahead.
What, they have to come up with money?
Recommendations.
they have to make a request in the next budget for
Right.
funding.
Yeah.
But I was going back and forth on what date to stick in there, and I suggested this one. And one of the things that Kaya Morris said really struck me, in that this is a huge group of people who've never been in the same room together, who have other jobs, who have other lives, and I think that giving them 15 months to really create the plan is even though I understand the urgency, I really do. I'm not sure that less than 15 months would give them enough time to get the work done. A year, I
Okay,
don't know. That's
know,
what I was thinking, but I'm open to an earlier time,
well,
Dave.
here's the thing. I think hearing Senator Cummings' question too, money in the budget. Senator, do you want to follow your comment up further?
No, I just know that this, if they can reassign people, but if it's new hires, you've got a hiring freeze on right now. I wish it were as simple as saying it shall be,
Yeah.
but
Well, let's try the January 2023. No date came over to us from the House. It was sort of
Yep.
ambivalent in the future. So let's leave it at that. That's the 15 months. Senator Hardy's comments are well taken. And then we'll see what happens going forward.
nothing says they can't come in earlier.
Nothing-
Right.
Yeah.
It says not later than, so they
Yeah.
could, if they get their work done earlier, it could happen earlier.
Was this the reason that the House left the date out, Katie? Do you know? That. Oops,
I'm muted, sorry. I believe this was added as a floor amendment, and I'll have to go back and check, but if my recollection is correct, then that means it didn't get a whole lot of committee discussion on that particular point. But let me check my file to see if that was part of the floor amendment.
thanks.
The date.
Yeah,
I think that the floor amendment was to change it to when fiscally feasible. I
Yeah.
think that was what the floor
think so,
amendment
too.
was. And there's concern that that would mean it would never happen. So I think having a date certain is really important. It's just
Floor
a matter of
amendments
what makes the
aside.
makes the most sense.
Yeah. Okay. I think I don't hear disagreement about that.
okay.
Good.
I will keep moving then. And where this list is all of the duties that the advisory commission has. One of the duties is to advise the Department of Health on funding decisions to eliminate health disparities and promote health equity. And the addition here is to also have to be authorized and requested to advise the General Assembly on funding decisions as well.
Yeah, this was the place where I think Kaya Morris was was feeling some language ambivalence. I'm not sure, but she'll have to weigh in if there is something more there.
Wait, I'm sorry, Senator Lyons, where were you just
I
talking
think it's
about?
around the funding piece, and I'm not positive. I thought it might be around page 19, but she couldn't find it when we were talking with her because she had different documents. So we'll hold off. Maybe there'll be something else, another sentence that she would like to modify or add. So we'll just go ahead.
I was thinking she was talking about the professional development section.
I think that's a different section.
Okay.
It said something about the
I
commission
can't speak for
capabilities.
somebody else. So we'll just see what comes our way.
Okay.
All right.
So that brings us to section 5. This was a report that came over from the House, and it had to do with providing guidance and recommendations for improving cultural competency and anti-racism in the healthcare system. And so to be consistent with changes that were made in the earlier section of the bill to add humility, that has also been added here for improving cultural competency and humility on line 7. And then in
wait,
section,
Katie,
oops, I'm sorry.
I'm sorry. I think this is the section that Kaya was talking about improving the language about cross communication between the commission and those who are doing the professional development. That was my understanding.
Yeah, I think what we heard that work is going on, but let's just look at the It's in consultation with licensing boards, professional organizations, providers of healthcare. I think it's pretty complete and it's really difficult. We don't usually, and Katie, correct me if I'm wrong, we don't usually name specific organizations. We could list all the licensing boards, but that might be sort of count.
Yeah, we would list a state entity. If it's
Yeah.
a private entity, we would tend to describe generally what that entity would be.
Yeah, so I think this, the way it's written is pretty inclusive, and obviously the Health Equity Advisory Commission can consult with a broad range of professional organizations and providers of healthcare and so on.
Okay. So I'll scroll down to section 6. This was an existing report that came over from the House, and the focus of the House report was budget recommendations for continuing the work of the Advisory Commission in fiscal year 2023 if necessary. And so this language just adds to what is coming in as part of that report. So, and I should say that this report, the Advisory Commission is required to submit an annual report. So it's at this section asks for that these specific items be addressed as part of the Advisory Commission's annual report. So we still have the budget recommendation piece. And then this is the language that was alluded to when we were talking about the challenge of coming up with correct definitions. So in subdivision 2, recommendations on appropriate and inclusive terms to replace the term non-white that is used in the new chapter. So there's that recommendation. And then there is a third subdivision, recommendations for most effectively utilizing funding received by the state pursuant to ARPA in a manner that promotes health and achieves health equity by eliminating avoidable and unjust disparities in health on the basis of race, ethnicity, disability, or LGBTQ status. So those are two additional things that this language would ask the Advisory Commission to report on. And I'm also realizing that I just need to reflect this number 3 in the title heading of section 6. So I will make that change when I bring a draft back tomorrow.
So, and I have a question, and this is really for the committee. As we were listening to testimony, we heard that there's a need for increased collection of data relating to health disparities and health equity. Is there anything that we could put in here that would support or allow for this group to look at what data is currently collected? I'm thinking most specifically through the Department of Health. The open question here. What thoughts on that, committee?
Senator Lyons, I was thinking along the same lines in terms of
You've got Katie taking us, there she is.
well, in terms of specifically in the section we were just in, but then I'll go to where you are, Katie, the recommendations on appropriate inclusive terms to replace the term non-white in 18 BSA chapter 6. Because I think we want them to make recommendations on how to change those categories for the collection of data also, not just.
Yes.
So,
yes. And that's for the Department of Health because they currently do it in a very specified way, which is what we're trying to get at. So.
Right. And
yeah.
often the data is collected as white and non-white. And that's why non-white is used in the bill so much, because that's what we have. So this would be like moving forward, how can we change those definitions to collect more granular and
okay, and
data.
and then yes, and I'm looking back on pages 21 and 22. Do we want to, Katie, go ahead.
Well, I was just flagging that this section existed to see if you wanted to look at this language more closely. I don't have specific language to propose.
I don't have a language changes to this necessarily, and I'm just wondering, it, this is a separate charge to the Department of Health. And the Department of Health is submitting its report containing the results of the analysis to Senate and Healthcare, Human Services committees. So my question is, what role, if any, will this advisory group play in looking at that, at that information?
Well,
And
it
how?
sounds like Senator Hardy is proposing that not only under this language are we directing state entities to be collecting data in categories, that are not limited to white and non-white, but on top of that, in the section 6 subdivision 2, adding language looking for the advisory commission to weigh in on what terminology to use, what categories to
Well, so
use
I'm-
when collecting data.
Yeah, so I'm going, yeah, right. So it talks about terms, inclusive terms, but to replace non-white, that's very specific to that. So my question is about the data, the actual categories of data that are being collected. So just to have some, that it could be as simple as saying on page 22 that the information from the Department of Health shall also be submitted to the advisory committee or to the Office of Health Equity. Committee, are you, just some thoughts from the committee on that one, if you think that works or not, or is it overkill? Hello?
I think it could be submitted to the commission.
It's up on their
The Office
website.
of Health Equity, once it's created, would be in the Department of Health. So we don't want to have the Department of Health reporting to itself, I would say.
Well, but we do want the Office of Health Equity to be involved in this process. So I'm trying to figure out how it goes, how it fits. And Katie, I'd look for you for some
Yeah.
help with that one.
Well, so I'm seeing this language that we're giving direction
Mhm.
that data related to race and ethnicity, we have to use separate collection categories. So that's a direction to state entities. And then we're saying, but this is to be done in accordance with recommendations made by the Executive Director of Racial Equity and in consultation with the Advisory Commission.
Okay,
So
that's
we're
good.
already
I-
asking for that feedback.
Okay.
And then in paragraph B, we're seeing that this information is publicly available. So I don't know that,
No, we're good.
okay.
Yeah,
But
no, I
Katie,
get it. I'm good.
that does bring up whether or not we're being inconsistent with who we're asking to come up with new definitions, because it seems to me that we might be asking 3 different people or groups. We're asking the Department of Health based on, in accordance with a recommendation from the Executive Director of Racial Equity. We're asking this commission, and then we're sort of asking the Director of Racial Equity too. So I just want to make sure we're being consistent. So is this language on page 22, section 253, is that consistent with what we've said at the end on the last section?
What I might recommend is in section 6, subdivision 2, maybe we cross-reference this language. So say that we're looking for this recommendation as part of the first annual report, and cross-reference here so that we're asking for the same thing in both places, and the second place just gives a deadline by which that recommendation is to come in.
Okay, that's great. Thank you.
That's good. And that may have been the question that the person who was testifying on this had, but I don't know.
Yeah, to make it more clear as to who
Yeah.
was in, charge of doing this or
Yeah,
responsible for it.
and I
Yeah.
think it was, the clarity needed was, we need an Office of Racial Equity to be involved in racial and health equity to do this, but I think that makes it clear. Thank you.
Yeah. The one other thing, Katie, in this very last section, given that we have put a date certain on the creation of the office, I think it should include budget recommendations for continuing of its work and establishment of the office, since it would happen in fiscal year 23.
Okay, I will add that.
Thank
Good
you.
catch. I would like to go around the committee, Senator Hooker, Senator Terenzini, Senator Cummings. Comments? I think Senator Hardy and I have been looking at this bill along with Katie right along, so it's a little different look that we're taking, but I need to hear from you folks.
Well, as long as the people who have requested to be included, the developmental disabilities people are included in this, and that it's clear that the definitions are going to be made in consultation with the commission and the Department of Health and all of the other people that we were charging with coming up with definitions. I think the clarity, I think, is important, and
Yep.
I think that you've done a good job of doing that. So I'm fine.
Okay,
I think it's the best we can do. I think it's a step forward. It's not everything everybody wanted, but nobody ever gets everything they want.
huh. I know.
Notice that. Actually, if anybody always gets everything they want, it's
We
not a
wouldn't be here.
democracy.
Right, we wouldn't be here. But I will
It's
say
not a
that,
democracy.
no, but Senator Terenzini is getting his added paycheck for being clerk.
Oh, right. I missed mine.
That's a shared joke, I guess. All right.
Is that on top of the chair's additional pay?
Oh, yes, all of it, all of it. Senator Terenzini, comments on the draft, and then the comments that you've heard going forward.
Yeah, thank you, Senator Lyons. I agree with Senator Cummings that it's not. It doesn't seem like it's everything that everybody wanted, but it's certainly a step in the right direction. I think it hits a lot of important points, and I think we heard good testimony today, and there's a lot of evidence to show that this is a good direction to move in, and it's something I support. So.
Terrific. Okay. So I guess where we are then is, Katie, you'll take that information and we'll see a new draft, and we'll be able to look at it first thing tomorrow. Let me just look at what tomorrow offers. Yeah, I think that it's on our agenda tomorrow, so we'll be able to look at that and vote it out. It's good. All right. Terrific.
Katie, I'll just try to get you language on that finding. But if you come up with anything too, if you have an idea, that's great too. But I'll see it on my lunch break.
I think if you go right to the Department of Health webpage, you'll find health data information on the risk behavior survey. There should be perhaps some data, and certainly with COVID, they've split it out, disaggregated it from other groups, so be able to find it. All right. Thank you, Katie. Okay, so let's move on to H46 that we have had in committee, and we can pull that one up. Katie, do you mind walking us through again that
Sure.
bill?
Let me pull it up. Okay, how did we do? Are you seeing it? Yes, H46. Okay, Not
Okay.
hearing that you're not seeing it, I'm assuming that you are.
Yes, we're
We
seeing
have it.
it.
I was muted.
Oh, okay.
It's,
Perfect. So just to give you a refresher, this is the version that came over from the House of H46, but this has various provisions, as the title indicates, of health, mental health law. So we have some language about different, in the second half, we have some language about some reporting requirements. And the first few sections deal with some notice to be given. So I'll go through each of the sections. So the first is you'll read in this lead-in language that before a person can be admitted as a voluntary patient, that person is to give his or her consent in writing on a form adopted by the department. And then there has been some language rewritten here. 1, 2, and 3 have just been broken out into a list. This was all part of one paragraph before. So when we added this item number 4, it started to get very confusing. So it seemed like breaking it into a list was the way to go. So the consent is to include a representation that, and this is the new language, the person understands that inpatient treatment may be on a locked unit and a requested discharge may be deferred if the treating physician determines that the person is a person in need of treatment. So that is, the person in need of treatment is kind of a term of art. It's a defined term to mean that you meet criteria to be held involuntarily. So that is part of the notice that's being proposed here when a person is admitted voluntarily. So that is section 1. Section 2 also has to do with notice being given to patients. And there's existing law about what the head of a hospital must provide in terms of information to patients. So that they have to post excerpts of relevant statutes informing patients of their right to discharge for other rights and for assisting them in making and presenting requests for discharge or for application. This is the new language, or for application to have the patient's status changed from involuntary to voluntary. So this is the new language that the individual has to be notified about by the head of the hospital. So that is section 2. Section 3, we have language about the, we have new language about the collection of information. So in this subsection, we have existing language that the department establishes standards for adequate treatment, including requirements that whenever possible, the staff be used as a primary source to implement EIPs, seclusion and restraint. And then there's this language, this reporting language, that the department shall oversee and collect information and report on data regarding the use of these EIPs, seclusion and restraint, for patients who are admitted to a psychiatric unit. And this is kind of the important part, regardless of whether the patient is under the care and custody of the commissioner. So regardless of whether or not the commissioner has custody, the department is collecting information about all times that seclusion and restraint are used on an inpatient unit. And then we move down to section 4. So you'll see that this is session law. This was a reporting requirement from a report that was adopted in 2018. So the proposal here is to amend this reporting requirement, and it's being amended in a couple ways. I'm going to scroll down. The first is that it's being extended. So it was supposed to be 3 years of reports, 2019 through 2021. And now we're asking here for additional years of reports. So we want the report to come in 2022 and 2023. So that's a change in B. And then you'll also see in this subsection A3 that we're striking out one of the criteria that was supposed to come in from the report. That's data regarding EIPs, the seclusion and restraint, and emergency departments on individuals seeking psychiatric care. And the testimony that I believe you heard was that the hospitals were unable to access that data or to provide that data to the department. So that has been removed from this report. And I believe that's the last section. Yes, our last section is section 5. Effective date is July 1, 2021.
all right, thank you. That was good, and thank you for reminding us about why that section was crossed out. I do remember that as you were talking, so. Committee, questions for Katie? Comments?
I did have a question about the application to change involuntary to voluntary and how that intersects with the knowing, the person knowing that the treating physician may determine that that person is in need of treatment. So, like, what does that application do? And is it sort of negated if the physician or the provider decides that they're a person in need of treatment?
So I think the concepts are kind of separate concepts, but I guess they could potentially overlap in one particular patient's case. But I think on the one hand, we have the ability for an individual who was admitted on involuntary status to petition to say that they would like to be on voluntary status. And what that would mean is a medical determination that the person is no longer meeting criteria, and they don't have to be held involuntarily, but they can continue to receive treatment, but they're not considered a danger to self or others. So I think that's one aspect. And I think the notice requirement that's here that says, if you come in on voluntary status, if you're voluntarily entering treatment, a couple of things are true. You might be treated on a locked unit. And also, if there's a medical determination that your status has changed, that you were not a person in need of treatment when you came into the hospital setting, but then a physician determines you now are a patient in need of treatment, then your status while you're in the hospital could be changed from voluntary to involuntary, and you wouldn't be able to leave the hospital until the medical professionals treating you found that you are no longer meeting that medical criteria of person in need of treatment.
Okay. Thanks, Katie.
But it's all based on medical determination, clinical determination. Other questions? Senator Terenzini.
Thank you, Senator Lyons. My curiosity is sort of piqued by this bill. I mean, there a lot of this you would already think would be in place, and there must have been something that has happened previously to have the House draft a bill of this nature. I was just surprised by much of it. Seems like common sense already and things that would be in practice. Do we know why this bill was originally created, or the history of how we got to this place, Senator Lyons?
Thanks for that question. Let me go. I'm not sure that I can answer it completely. I do know that the issue about patients' rights has always been, I just lost the bill, has always been important. And so this is an updating to patients' rights. Katie, and then also the crossing out the line is based probably on a request that, sorry, my phone is ringing, that the hospitals cannot track that data. So to me, it reflects a cleanup, and I think there's always been concern about seclusion and restraint issues. So who was the lead sponsor on this one? It was probably
Representative Donahue. Was
Donahue,
the lead
and
sponsor. Mhm.
she's always had a in-depth interest in the treatment of those with mental illness in the system. So I would suspect that this is part of her ongoing interest. And we've, in this committee, we have looked at the emergency department issue for mental health folks having to remain in emergency departments, and whether or not they are voluntary or involuntarily treated, and that whole issue gets to be extremely complex. I think we're almost blessed with a bill that is fixing a few sections of law, and that we've heard from folks are relatively not controversial. So I can't help you any more than that.
Oh, it just, it
Yeah.
seems straightforward to the point. Yeah, thank you.
All right. Senator Hardy.
Thank you, Madam Chair. I'm hesitant to say this because I just have a specific language change potentially in the very first paragraph B on page 1. You made some changes when you did the enumeration that got rid of he or she,
Mhm.
and it doesn't get rid of he or she in that first paragraph. So I'm wondering if it makes sense to say before the person may be admitted as a voluntary patient, the person shall give consent in writing on a form, and that gets rid of to he or she's. Just to keep the language consistent. I know we're trying to avoid the gendered pronouns.
Katie, does that make sense?
I can make that change. Yep.
Good.
Does
Okay,
does
well,
that make sense, Katie, though? I mean,
Mhm.
Yeah.
I'm looking at subdivision 1 too.
oh, right,
You were referring to subsection B, but
correct. But subdivision 1 also probably. That one, I don't know how to change it though.
subdivision 1 is tricky, which is probably why it stayed the way it was. But in subsection B, we could say the person may be admitted as a voluntary patient.
Well,
Let's see.
subdivision 1, you just take out and just say the person understands that treatment will involve.
Okay,
Yeah, I don't see a need for the his or her there either.
okay. I can make those changes for you.
Okay, can we have a strike all, Bill, or are we going to do an amendment?
Seems like we could do an amendment for those little changes, but I don't care that much. I just was looking for consistency.
I think it's sometimes easier for the person reporting the bill to have a strike all, but Katie, I leave it to you.
I wonder if you could just strike that one section instead of having to strike the whole bill. And we'll just do a clean strike out of 1 and propose in lieu thereof a new section 1 to read as follows. Would that work?
Yeah,
Okay.
we'd still have 1 through 4.
I'm not sure I follow.
We're still going to have a section 1. What are you doing? Explain again.
I'm just saying, instead of doing a whole strike through of the whole,
Oh,
strike all of the whole bill, just striking section 1 and putting a new section 1 with the changes in.
okay. Perfectly fine.
Okay, I will take care of that.
Perfect. And so then that would be the last iteration of this bill, hopefully.
Okay. I can see if I can get that to you. I'm not sure what your plans are for today, but maybe I can get it to you before you adjourn.
Okay, if you can do that, we can hold a vote on the bill.
Okay,
We've got, Jen is here and we've got a lot of bills to go through with her. It may be early tomorrow morning along with 210. So however it works, we're going to be moving quickly. Thank you. I have a question before you go, Katie. And that is, if we moved our time to 8:30 tomorrow morning,
no, I have another appointment.
if you came in later in the day, I'm talking to I want you to hear this, but
Oh, I'm sorry.
yeah, no, you're good. You're good. So you aren't on the agenda until later in the morning, and that can happen. So you're already on the agenda later with this bill and the others.
Mhm.
Why is it Senate floor got stuck in there? Committee, can we meet at 8:30 tomorrow morning? Look at Ann. Oh, Ann.
I might be a few minutes late, Senator
Okay.
Lyons. We have a caucus. We have a caucus in the morning.
Okay, well, Nellie, let's put 8:30 up on our agenda for tomorrow, and hopefully we won't need all that time, but you never know. I think it's good to do it. And Katie, you come in when possible, and then we'll hear from Jen in a minute about her. situation. So thank you. All right. So we're going to move on to the bills that we have from Jen. And Jen, the good news is that I did hear from House Healthcare, and they were fine with H 430 as we have proposed, we are proposing it. So why don't we jump to that one?
Great. All right. So I had sent Nellie some new drafts just a little bit ago, and I don't know if she's had a chance to put them up yet, but I can put the language up.
Okay.
They are
Um,
posted.
Oh, okay. Great.
I just wrapped posting them.
Oh, you sure did. I saw the numbers. I saw there were still 3 documents and I thought it was the same ones. Thank you.
What are we looking at, Jen? I'm
We
sorry.
are looking at H 430.
Yeah, thank you.
Sure. And I will put that up.
And it's a strike all amendment.
That's right.
Okay, so it's not as passed by House.
Can't hear you.
No, we had looked at, she was saying it's not as passed by House. We had looked at some potential language yesterday that wasn't in amendment form, and now I've put it in amendment form with some additional changes to reflect your discussion from yesterday.
So Senator Cummings, if you refresh your page, it will come up.
That's what I'm doing.
So
This
it should
is
say
the-
draft 1.1, 422.
Yep, I've got it. Strike all amendment. It came up.
Perfect.
Yep.
Great. So for the record, Jennifer Carby, Legislative Counsel. I did go over that language yesterday that we had with the House Healthcare Committee after we had looked at it in the morning here. They had asked some other questions that I've been following up with Diva on about some more specificity in the types of as far as what's covered under hospital, medical, dental, and prescription drug coverage, and also potentially tracking, instead of using the specific income or federal poverty levels and the time, the duration postpartum, the House was interested in potentially trying to tie that in more to what's done in Dr. Dinosaur, which is a little tricky because we're trying not to tie it in too much with Dr. Dinosaur because of the eligibility issues. So I'm still working with Diva on that, but they have been looking at that, and we've been having some correspondence on that. And I think they also wanted to note that some of that would be a policy decision because the fiscal estimates were based on the specific points, the poverty level and the 60 days postpartum. So I just wanted to put that out for you. What I have shown, yes.
Yep. So all of which is to say that we'll probably see some language changes before we vote on this bill tomorrow morning.
You may, right.
okay.
But I will show you what I have done. So I've marked in green just to try not to confuse us with what we'd looked at as different stuff yesterday. The language that I have changed as a result of our discussion in here yesterday. So the first has to do with the confidentiality. So we're right in that section in Title 33 that requires the coverage to be provided. And then we would have language that says the confidentiality provisions set forth in Section 1902A of this chapter, which are the ones that apply to Medicaid records and applications, shall apply to all applications submitted and records created under the authority of this section. Actually, I think I was going to change that to pursuant to this section, but I must not have done that. Except that the Agency of Human Services shall not make any information regarding applicants or enrollees available to the United States government. And that is because there is language specifically in 1902A that says all this information is confidential and shall be made available only to persons authorized by the agency, the state, or the United States, because it's a Medicaid program. So in this case, we're carving that US government piece out. It's a state-only dollars program. Information would not be made available to the federal government.
Okay. You're making me feel like a secessionist, but we'll go with it.
Thank
And then
you,
I've
Jen.
just,
I think that that language is really important for the people who will be using the program. So thank you.
Sure. And then I've put some language in the outreach and education or outreach and information piece about it as well.
Jen, I don't know if I'm looking at the right one still. Is my version, should it have the green highlight on it?
Yes.
Yes, you should. So I just went up to the top. It should say draft 1.1 H430 4/22/21 8:42 a.m.
Refresh your browser, refresh your page.
If yours says as introduced by the House or as passed by the House at the top, it's not the right one. But you
Click the
don't get
little-
highlight until page 2.
Okay, I refreshed. I took Senator Lyons' advice, refreshed, and I see it now.
Okay, great.
Thank you.
All right, then we get into section 2, that is the outreach and provider grants. And so the change we had discussed in here yesterday, and I did make these, I didn't show you all of the little punctuation changes. I did make these standalone sentences because I'm adding a second sentence on number 2. So we have grants to Vermont organizations that work with members of Vermont's undocumented immigrant community or members of the healthcare provider community to provide, and then you had requested yesterday, culturally and linguistically appropriate outreach and information. I'll pause there and just say that they, at least one of the members of the healthcare committee particularly commented on liking that language and appreciating that addition. So this outreach and information regarding opportunities for children and pregnant individuals in Vermont who have an immigration status for which Medicaid coverage is not available to access healthcare services at low or no cost in fiscal year 2022 and thereafter. And then a new second sentence that says the outreach and information shall include information on the confidentiality of records pertaining to applicants and enrollees. So that would be part of what's getting communicated to people who would be applying for the coverage. And then I think that's it. Yes, I think Senator Hooker had pointed out an important change in the name that I have carried over here. So it's just eligibility and it's not expanding eligibility.
Okay.
That is that.
So you're still working to fine tune the,
Right, I am still working with DEVA and the House Committee to see if there's language that can or should go in there. And as I mentioned, DEVA pointed out that this is to some extent a policy decision because it may affect the fiscal impact going forward if these numbers change in the underlying reference program, which is the Dr. Dinosaur program.
Madam Chair,
Go ahead.
I'm not sure I understand what they're looking for and whether I would think it's a good move, you know?
What the House is looking for?
Yeah, what can you explain?
The issues that were brought up are, well, what if the 317% of FPL or the 213% FPL changes for Dr. Dinosaur, and then this program would not be aligned with the eligibility levels for Dr. Dinosaur. And similarly, under ARPA, there is a state option to provide coverage for pregnant individuals for 12 months postpartum that I think we can elect next year for up to 5 years. So what if we did that, and then we would need to change this statute if we wanted to align?
so
that
my
coverage.
my
Oh,
thinking
I see.
about that is just as we have made changes early in sessions that we feel are really important, we can come back and make these changes. You know, I don't think we can legislate for every possible expected change in the future. Maybe there's language that can do that, but once we link it to changes within Dr. Dinosaur, I think we put the recipients in jeopardy again, and the program in jeopardy. Is that?
It's my understanding, I mean, I think DEVA was more comfortable not having specific
Okay.
specific reference to the Dr. Dinosaur program because it is so specifically not the Dr. Dinosaur program, even though I believe they understand that your intent is that the benefits would align.
That is. but I mean, may have to come back and pass a quick little statute.
Can I ask a question about, in section 3, the fiscal year estimate thing?
Mhm.
The Agency of Human Services is providing information on the fiscal year 2023 costs to our committees. When is that supposed to happen? Is there,
Well, it's part of their FY23 budget presentation.
I
So
see.
that will be during the next legislative session.
Could we just add language in there that says something about and any changes to eligibility that may be necessary or something, and be done with it there? Just, asking them to, if there are updated eligibility recommendations, and then we don't have to reference anything else and we all kind of know what that is. I don't know if that covers it or not sufficiently, but it's just an idea of a way to get around it.
Yeah, I think some of the concern was not necessarily that there would be a change in the eligibility in the next year, but potentially further down the road.
Mhm.
I'm not sure having the
Oh.
recommendations come next year necessarily addresses the problem. Maybe something you want to address offline with, the chair may want to address offline with the House to see
I will.
where they're at.
I will.
Okay.
We'll do that. Okay, are there any other questions on the draft in front of us?
Are we gonna have,
and I-
are we gonna have a discussion, Senator Lyons, on this further, or are you looking to
Yeah,
move
yeah,
off
no,
of this bill
I
right now?
want to have discussion further. I was waiting to see if we could take the bill down before we did that.
So my only other point, I think I would prefer, I worked on some of this language with Diva as well. I prefer to change this piece right here to pursuant to this section rather than under the authority of this section, if that's okay with everyone. I don't think it's
Yeah.
has a substantive distinction, but I think it's more in keeping with our language.
Sounds good to me.
So
so-
I will,
So why don't you do that, and then we can there we go. And now we can have our discussion. It sounds like we're going to be seeing some language changes tomorrow morning, and then possibly entertain a vote. So discussion committee, Senator Terenzini.
Sure, thank you. This added language, well, let me back up. I, spent a lot of time yesterday and last night thinking about this bill, and thinking to myself, we're talking here 100 or 125 children who are here in Vermont who right now do not have the means to have a doctor's appointment, a procedure, medicines if they needed it. And I thought to myself, what if this were one of my 4 kids who are blessed to have health insurance? And then I said, these are, in my mind, they're all God's children, and they're all special. And I'm going to support it for that reason. However, I'm a little uneasy about this new added language because,
Which
it's one thing
language?
for us to provide the health and, I'm sorry, the section
Uh-oh, you
in
froze.
green on page 2 that talks about, am I here?
Now you are. You're going in and out.
I'm back.
Yep.
Let me turn my camera off. Jenny, hold on.
Okay, that's good.
Is that better?
Yeah.
So my concern really here is this added language on page 2 in green about the confidentiality provision. I mean, in my mind, and I'm trying to be very sensitive here, but we would be providing coverage for children who are here undocumented. In other words, this is suppressing, if the immigration department or the federal government wanted to come here and follow federal laws about immigration, we're suppressing records that the federal government might want. In other words, myself and all of us as citizens of the United States, we don't have this kind of individual protections and privacy rights if the federal government was looking for us. So unless I'm looking at this completely wrong, I think we're taking it too far. These children are here they need to be healthy, but this isn't settling well with me. And I just am very uncomfortable about this whole section.
So think about this. I think right now we also have a driver's license program through the DMV that allows for undocumented workers to drive, but that information is not reported. This one would be a confidentiality of healthcare information that would not be reported. And it isn't, we are allowing for some, I would guess it's comfort level on the part of the recipients. So the mother taking the child into the pediatrician or the pregnant woman who's being going to the clinic, she may be very hesitant. Either one of those could be very hesitant to going into the clinic or see the physician or the nurse practitioner, whomever it is, because she's afraid that just by going into the office, she'll be reported as an undocumented immigrant. This protects that person in that one instance. It doesn't in any way eliminate the federal government's authority to identify someone and move them as the federal government will. So it does become a policy choice, but I think it is a choice that allows for people to access health care while they are here, whether or not they are documented. And so I couldn't say further about that, Senator Terenzini, but I think it does get to the point that you made early on. It allows for all children, regardless of their documentation, to be in healthcare. Oh,
Well,
and one last thing. Let's put a hypothetical in place. If the federal government passes a law that says all healthcare providers must report whether or not a patient is documented, I don't know what that means. It means people won't access care.
I appreciate your comments, and just so the record's straight and my committee members know, my heart and you know where I'm at. And I come at this from a place of love, but not, I'm not suggesting here that I want to see the federal government or ICE or anyone sweep in and move people out of Vermont. These folks are here for a better life, and they're here working jobs that, quite frankly, a lot of Vermonters don't want these jobs or choose not to work these jobs. I'm not suggesting that. I just, this language caught me off guard. Yeah. And I felt like we were taking it a little further. I am encouraged just this week that, President Bush has come out of retirement a little bit, and he's on the stump for immigration reform, because we know as a country, we need desperately to stop being so partisan, and we need bipartisan immigration reform in this country badly. And this could help. If we did, this could help our problem here. But anyways, I appreciate your comments. It's still a little bit of a sticky point, but these kids deserve health insurance, in my opinion, to be able to see a doctor, get some medicine, and get a little inhaler, or whatever it is that they need,
Senator Cummings.
Okay, little history. We did the driver's license in part to prevent human trafficking. That migrant workers are very vulnerable to being trafficked. If a farmer takes their documents, they can't get off the farm. And we did several pieces of legislation to prevent that kind of abuse. The farmers need the workers, and if they were only picking apples for 6 weeks, they could get a green card. But the cows need to be milked 365 days a year, and we haven't allowed that. My base question is, I'm assuming that the Dr. Dinosaurs are confidential information under HIPAA.
Yeah.
So
the healthcare data is.
Yeah.
Jen will have to answer that question.
Right. So treatment information is, I don't know that necessarily application for coverage under Dr. Dinosaur is HIPAA protected. It is confidential under section 1902A, which is the one that we're piggybacking on.
All right, so we're doing equal status. I'm also assuming that if the federal government wanted the information, they could go to court and get a subpoena.
They could try to, I mean, then there would be,
Yeah,
the courts would
but I
have to
mean,
decide. Right.
it isn't,
I don't,
like we
right. I don't
burn
know
it.
what the result of that would be.
Right.
So
that
the
would be a
difference,
court decision.
right. So in general, you're treating them the same as under Medicaid, with this difference that the information is not available to the federal government. It is also a state only funded program as opposed to a state federal funded program, the way Medicaid is. So
I also got the impression, because we were worried during COVID when we were trying to do some things, and there was and it was the advocates, I think, that were running the clinics that said,
Yep.
they know we're here.
Yes, I know.
They're hanging around. But if they wanted to,
They could.
they wouldn't have to go for health records.
Senator Hardy and then Senator Terenzini.
Thank you, Madam Chair. And Senator Terenzini, I do appreciate how you always speak from the heart, and that you have been supportive of this bill since the beginning. And I just want to reiterate the importance of having this confidentiality language in there in order for women and children to be able to access this program. There is a history, recent history and current history of families being separated from each other, mothers and children being separated because of immigration status. And I know that people will not use this program if we don't provide them some guarantee of confidentiality as best as we can. And I think this language does that. And so if our goal is really to make sure that children have access to healthcare and expecting mothers have access to healthcare, we really need to have this language in here. And it is consistent, as Senators Lyon and Cummings have said, with the law that we did, or prior to my time here, but that was done about driver's licenses, and also recent legislation that we passed related to stimulus equity payments for people regardless of immigration status. That was a tripartisan, supported by the administration and the legislature, and it included similar language. So I think it's really important to the goal of this legislation to have it in there and ensure that the people not only have access to healthcare, but also access to protection from having their families torn apart. So I appreciate your comments, but I hope that you'll continue to support the legislation as is. Thank you.
Senator Terenzini, you had your hand up as well.
Thank you, Senator Lyons. Thank you, Senator Hardy. I appreciate the comments. The last thing I want to make it clear, the last thing I want to see is a mother and child or children separated. I mean, I think it's a crime what's happening on the southern border right now with separation of families, and I think several administrations have been guilty of it, both parties, and it's a disgrace. I think it's a failure on both sides. And I certainly don't want to see these Vermont kids get separated from their parents. So I think I'll stop there, and I appreciate the dialogue, and it's an opportunity for us to do something good at the end of the day for these kids that need to see a doctor. So.
Okay, thank you. Jen, I think what we'll do is we're going to shift gears, and then we'll look for language changes when we come back tomorrow morning on 4:30. And if you have something before then, maybe you could send it out, and we'll have the committee be able to look at it ahead of time. That would be helpful.
Sure.
Okay, and so I think what we should do at this point, because we have it's called spam risk. That's what I just got. I think we should move to S-120 and go through the bill. And we heard a lot of testimony yesterday. I have some suggestions for change. to the bill. And so can we, committee, my comment is this. We've heard a lot of testimony. I've put in a proposal, and I'd like to make further changes to that proposal on S-120. I pulled out some S-132 sections and put it into 120, and I'm hoping that we can work from that, unless I hear a hue and cry. I'm not hearing a hue and cry.
I'm sorry. Can you repeat that, Senator Lyons? I
know you're all preoccupied. I got that message. I'm asking if we can work from the proposed amendment to S-120 that I put out on the webpage yesterday as we go forward. And we also heard testimony from folks yesterday about making changes to that. And I also have some suggestions that I would like to make, and I'm sure that each one of you does as well. That's what I'm saying.
Okay, great.
So,
And I put what you looked at yesterday into a amendment format so we can be sort of working from the same document going forward. And I did put in that additional section, Senator Lyons, that you asked for last night or this morning in this new draft, and it's marked
okay,
as
that's good.
new.
And
You can see it.
so I know that the insurance companies are here, and we've asked for them to provide. Charles Storrow is here, Sarah Teachout is here, and I think that we should hear from them very briefly. You have sent us testimony in writing. I did hear from Jean Kennedy representing Cigna, who was said that to do the hearing aids would have been is a great deal of work, and they don't have that data. So let's hear. We have 15 minutes left, 16 minutes left. So let's hear very briefly from MVP and Blue Cross and Blue Shield. And so I don't know who wants to go first. It's always a coin toss.
Good morning, committee. Chuck Storrow here from Leonine Public Affairs on behalf of MVP. I'm more than happy if Ms. Teachout goes first, but I'm happy to speak too. But Sarah's got a more comprehensive sort of message than I do. So I'm happy to and suggest that she go first.
Okay,
Sure.
and what I'm going to do is I'm going to limit you very much in time since your testimony is in writing, but please
Okay,
go ahead.
you only want to hear about hearing aids. There were a couple things. One is that I can't remember which draft that you had January 1st, 2022 for large group fully insured to include hearing aids. I just wanted you to know that that's pretty much impossible to do. The rates have already been filed. The hearing has been waived. All of the comments are done, and we are awaiting the Green Mountain Care Board decision on May 11th about those rates. So it's just really too late for 2022. I did want to be very clear that the actuaries worked on this estimate before any final, decisions were made and the bills were released. So some of the assumptions that they made do not align with what you have been discussing. And also no group in the state of Vermont has chosen hearing aid coverage to date. So none of our data is specific to Vermont. So I can just tell you that quickly we use information about the number of people with hearing loss and the adoption of hearing aids nationally. We adjust it for the population that we're covering. And the one point there is that clearly it's the age of the population is important for that type of coverage. We use just a pricing survey data to try and determine how much people will spend on hearing aids. The range is between $1,600 and $2,600 per hearing aid. So you have to double that if you have two. We estimate it's about $2,000 per user. Not every person requires two hearing aids. We assumed the same cost sharing as for all durable medical equipment. And then this is key. We assumed a 3-year benefit period, which I don't believe is in your bill. So this is an estimate over a 3-year period. So keep that in mind. Over a 3-year period, the increase to cover hearing aids for fully insured members is estimated at $7.52 per member per month. That's $90.24 a year, but we're not talking about a year. We're talking about a 3-year period. That's equivalent to a 0.8% increase in premiums over a 3-year period again. And due to pent-up demand, it's possible that the majority of these claims may be in the first year of the benefit period. I was told by our actuaries that I can't take that number and divide by 3. So that's why I've given you a 3-year estimate. And I'm sorry I can't do that, but that would make the data inaccurate. So I did provide some information about other states' coverage on the chart below. I don't know if you've ever seen this before, but I would note that almost every state in some way caps the cost of the hearing device. And then most of them have a frequency for how often they may be replaced. So those are 2 methods that these states have done to rein in the costs of hearing aid coverage. So Blue Cross does not oppose in any way the coverage of hearing aids. We just want everyone's eyes wide open to the impact on premiums.
All right, thank you. And Nellie, I don't see, I've refreshed, but I don't see the testimony up. I've seen it myself, but I don't think it's on our webpage. Where's Nellie? Nellie?
I'm here.
Okay.
I apologize. I'll check
Okay.
that out and work to get it
And
posted.
the same with, I think also Chuck Starrow's is not, MVP's is not up either. So that testimony. So also Sarah, thank you for that. And is there any section of 12, 13 or 14 sections of 132 that fit or not in terms of moving forward? I know we did put language in our budget bill, our budget recommendation to support the work that DFR is doing with a variety of folks on hearing aid coverage. And do you support that?
We're very supportive of that approach.
Okay, all right. Okay, thank you. Chuck.
Thank you, Madam Chair. Chuck Storrow again for MVP. Basically we'll echo what Sarah said. MVP has not been able to actually crunch the numbers and come up with an estimate. Their presence in the large group market is relatively small, but it does stand to reason that if you add benefits, it will have pressure on premium. With respect to section 13 of S132, oh no, excuse me. I do have one question though, in section 12 of 132 on page 18, line 3, subdivision 2, a covered individual may select a hearing aid that exceeds the limits set forth in subdivision 1 of this subsection and pay the additional costs. And it just, maybe I'm missing something, but subdivision 1, which is right above, doesn't set forth any limit. It just says that the only coverage limit is medical necessity. So that's really more.
So that would be the limit. So if somebody wanted something more than what is medically necessary, they can get something, a fancier something, but they have to pay the additional cost.
Okay, all right, that makes sense. Okay, I was looking for a numerical limit or something. But as Sarah pointed out, other states that do this do have dollar limits or frequency of replacement limits. We think those would be appropriate to try and manage the costs in all of this. With respect to individual and small group plans, the effort here would be to get CMS to modify the benchmark plan. That would essentially include them as an essential health benefit. Again, we're not in a position to give a numerical estimate of the impact on that. One thought that does come to my mind though, and I could be wrong, but I have it in my mind that if you add benefits, there's exposure on the part of the state for the additional cost of subsidies for people buying exchange plans. I'm not sure if that's at play here, and it's beyond my knowledge as to whether or not that's actual factor, but I would suggest that you take a look at that issue. Essentially, my recollection is if states add benefits mandates, then essentially the states pay for it in the form of the increased subsidies that are needed. But as we set forth in that memo, it does seem appropriate that if DFR is going to conduct an actuarial analysis of changes to the benchmark plan, and if that's specifically going to be including the issue of hearing aids, that that go forth first before any application is submitted to CMS.
Okay, thank you. That's helpful. And I think the leaf is falling to the ground slowly, and we get it. We understand.
Thank you.
Yes. Okay. So Jen, we have 8 minutes. My suggestion is this: let's look very briefly at the. Well, no, I'd like to open it up for committee discussion, I think, and listen to what your thoughts are based on the testimony that we've heard around the proposal. And I am sticking with the S-120 proposed amendment that I put in yesterday. And I'm gonna start first.
Madam Chair, can I address
Yes.
the state defrayal piece? Because I think there
Yes,
has been some
yes.
confusion around that.
Yes.
So as Chuck mentioned, there is a requirement for if states add benefit mandates after 2011, the state is on the hook to defray, to pay the cost of the additional premium, not just the subsidies, but the additional premium attributable to those additional mandates for the individual and small group market. That's the reason that the bill, as you see it, has coverage start for the large group, which is not subject to the state defrayal, and then looks at changing the state's benchmark plan to build the hearing aid mandate in with the mandates, which also would require then some reduction, a commensurate reduction in other benefits to account for that. There's a generosity test that's all part of what DFR and the others are going to be looking at and doing that benchmark plan review. But if you just required hearing aid coverage starting next year or the year after in the individual and small group market, the state would be on the hook to pay that additional $90.24 or whatever it ended up being that that Sarah mentioned for each policy holder, each covered life. So again, there was at one point in an early version of what became the Affordable Care Act, that state defrayal was linked just to the additional subsidies, but as codified, as enacted and as codified, it does apply more broadly so that the state defrayal applies to everyone enrolled in the plan.
Thank you. Senator Cummings.
Okay, if we do this, is the end effect, we are adding to the cost of essentially state employees and teachers' health insurance. They don't have any way to negotiate out of this.
If you add this as a mandate for the large group, including the, so as written in the bill, it would include the state employees and the teachers. Yes, it would be a required benefit. So they could look to reduce other benefits to balance it out if that was the desired result. But it would make this a required covered benefit.
Maybe we should hear,
Go ahead, Senator.
maybe we should hear from the state employees and the teachers, VSEA and the NEA.
We had them in, but this was not, they didn't comment on that specific issue
I mean,
specifically.
given all the issues with potential increased pension cost, I'm not sure how well received this might be.
So my suggestion, I think, is that we have done a lot of work to add the benchmark discussion into our budget recommendations. And it would be my suggestion that we use that as our position on hearing aids. I think this is much too, it could be much too costly for people, and it is more complicated. Oh, I forgot. That's our bumper sticker. It is
Our
Or
motto, I think,
complicated.
yes.
it is our motto. I was going to say it's a bumper sticker in the committee room. So, I think that unfortunately everyone loves the concept of adding hearing aids in and making them available. I've been trying for this one for a while, so I think I think unless I hear differently, that it comes out of the bill. Those sections 12, 13, and 14 that were in somewhere.
Madam Chair.
Yeah, go ahead.
Thank you. It seems to me that it would be good to get the data from DFR and the analysis from DFR before we move forward. And since we can't do it for the next plan year because we're too late along the line, we do have a little time before the following plan year. Isn't that correct, Sarah? Yeah. So for the 2023 plan year. But I wanted to just inquire, Madam Chair, if you know, did the Appropriations Committee accept that recommendation to include the language in the budget?
No, that was my next comment. I don't know. And we certainly could add language into this bill.
Do you
That
know, Jen,
supports that work.
were you in committee with them yesterday?
I have not been, no, I've not been asked to be in there yet.
Okay, because I do know they went through at least some of the provisions in our recommended memo.
I
And
think this was the least shocking.
yes, I mean, this doesn't
I
cost
believe
any
I
money.
heard the word catatonic from the chair.
Oh, nice. Well, anyway, I just want to make sure that they accepted it. And if we need to somehow reiterate it through this bill, we could add the same language in this bill if necessary, but I don't know.
So, and I do have a phone conversation coming up with the Chair of Appropriations, so we will find out. My ears will be filled. Okay, so the documents from Blue Cross and Blue Shield and MVP are now up on our webpage. We are out of time, but tomorrow morning, Jen, where did Jen go? Oh,
Still here.
This terrible when the screen shifts around. So we're beginning our work tomorrow morning at 8:30.
Okay.
And I would like to have Katie can't be in until later, so you are on for 9. Can you be here tomorrow morning at 8:30 to dive into HS 120?
This week I can. It's school vacation week, so I don't have to do the school run in the morning. So
Oh,
yes.
terrific. Oh, all right. So let's do that. Let's start out with one. I know we have all those bills on our list. We'll do 120, then we'll circle back to the other bills that Jen has been helping us with. My suggestion on 120 is to look at the testimony that we've had yesterday. I do have some improvements that we could make and some sections that we might delete, and I would like for you to do the same. And we'll dive into it. I may send an email out to the committee later today on this bill. So, Senator Harding.
Could I just make a suggestion that we start with H104 tomorrow morning? Because I think that we could probably just pass that one out, and it's the telehealth, and then move to 120, which will take a lot more time. I'm a let's check something off our list person, so I think that one would take 5 minutes, and then we could go to 120, which will take a lot longer.
That's fine with me. I just think that the 120 is going to take a little more time, and we also have 430 we want to go through, and then 210.
Yeah.
46. So there are a lot that we could check off, but if we haven't looked at H104 today, so that's fine. We can start with that. Jen, that is your bill, is it not?
That is my bill, and I have
All right,
a very
let's do
short
that.
amendment for you.
Yes.
It's
good.
on your website.
And
Yes.
Katie just sent us, Madam Chair, the amendment for 46, the mental health bill that we just.
We
talked
might be
about.
able to check that one off quickly, but
Yeah,
we'll have to do that when Katie comes into the committee. So we'll start with Jen, and then we'll move on to the other bills that we have. We'll start with 104. That makes a lot of sense. Okay.
And if Senator Lyons, if my caucus is not over by 8:30, I'll leave caucus to be here so I can take the roll call votes and do my clerk job.
Oh, okay.
Yeah.
Keep me posted on that. If something urgent comes up in caucus.
Yeah,
let
yeah,
us-
no, I think we'll be fine. So
All right. Nellie, we're finished. We can go off, and we'll